one another as well. So I appreciate the fact that it happened on the same day as well. So I'm here to tell you a little bit about our Tribal Behavioral Health Providers Association. Um, and I'll probably skip one of them, but I will start with our land acknowledgement. The New Mexico Tribal Behavioral Health Providers Association humbly recognizes and acknowledges that we are on unceded territory. Oh, look at that. My computer's starting to overreact. Territory and ancestral lands of the original peoples of New Mexico, Pueblos, Apaches, Nations, and Navajo Nation. Together, we acknowledge the history of genocide, disposition, colonization, and ongoing systemic inequities while strengthening and respecting relationships with Indigenous peoples. We give thanks to the past, the present, future stewards of this land and respect all tribal nation sovereignty. In offering this land acknowledgement, we affirm Indigenous resiliency, self-determination, and self-governance of New Mexico's tribes, nations, and who are still here today. And we are extremely thankful for all of the nations that take care of the land, that provide us food and a place to live, and a safe environment in New Mexico. So wanted to start with that land acknowledgement. Um, there was already an introduction, so there is no need for another one. Um, so the history of our Tribal Behavioral Health Association, um, before we get into that, we want to talk a little bit about the history of behavioral health in tribal communities, because I think that it's really important for us to kind of know a little bit about that as we move forward and look at behavioral health associations and the work that happens um, through our behavioral health providers. So the Indian Self-Determination Act happened in 1975, and it actually empowered tribes to create their own programs with federal funds. Now, the early programs that actually were established just happened to be substance abuse treatment programs. And they were developed, I'm sure you've heard now, 638. They've 638 at their behavioral health contract. That's used a lot, but I think a lot of the times we don't really look at like, what does that really mean? And that really came to having some ownership over own programming, right? And then again, because substance use is such a disproportionate um, problem in our communities, that those were the ones that were originally 638, and then behavioral health in general started becoming 638. We're still currently having some programs that are 638 in their behavioral health, and so it's still continuing to happen. It's not that it happened 10 years ago and it was a one-time opportunity. It is still taking place. Now, funding was still limited under these contracts, and there were a lot of restrictions around them. And until 2006 is when behavioral health reform in New Mexico um, allowed tribal behavioral health programs to bill Medicaid for their services. And I'm sure you've heard that there's a OMB rate that ends up paying for tribal services that are different than any of some of the Medicaid codes that pay for behavioral health for non-tribal programs. And so I think within our tribal communities and tribal behavioral health, we want to protect not only the services that are being provided, expand some of the Medicaid codes. And that's something that we as an association really focus on. There's a couple of Medicaid codes now that are available at the federal level that are not available at our state level. And then there's the um, tribal behavioral health healing services that we had a lot of input at the federal level before those codes became open here locally. So that just tells you a little bit of the level of input that we as a Behavioral Health Providers Association have when it comes to Medicaid. Um, and then there were still a lot of, and continue to be a lot of gaps within behavioral health in tribal communities. And so thus the kind of the birth of the Behavioral Health Tribal Association. Okay, so the case for a tribal association, we knew that there were a couple of native focus groups such as the NASC, or the Native American Subcommittee, and the NATAC, which is the Native American Technical Advisory Committee. And so for us, we wanted to know, is there really a need for this association to focus on behavioral health providers? We also knew about the Non-Tribal Behavioral Health Providers Association, and we're wondering, do they have tribal behavioral health providers within their association? And they did not. And then we needed to find out what were some of the barriers to their association not having tribal providers, or why not tribal providers were not applying to be part of that association. So we just kind of had to do a lot of research. So we did a needs assessment. We also engaged stakeholders and focus groups. And this was in addition to what I'll tell you in a little bit was already taking place. And it did not necessarily have a focus on the tribal association, but it was a larger assessment that was happening statewide. So there was a lot of, so this slide really focuses on the due diligence that we took before saying we're going to actually host and create a Tribal Behavioral Health Providers Association. Okay, so some of the things that we had identified were needs of behavioral health providers, and this is high level because all of these have a lot of subcategories. But for example, obviously substance use was one of the primary needs that our tribal behavioral health providers said they wanted to focus on because it was impacting behavioral health, right? So either behavioral health leads to substance use, or substance use leads to behavioral health. But they're so intertwined, and there's always co-occurring situations, and that included alcohol, opioid, meth, prescription pills. In general, substance use is something that our providers really wanted us to focus on. Medicaid billing was another one, and billing MCOs and contracting with MCOs was another one. Those are because a lot of the times, if we have providers within the tribal communities, so our association is open to any provider that offers services to tribal clients. So that can mean either you are a provider that has behavioral health services within a tribal community, or a provider that's outside of a tribal community, but your focus is on tribal members. And so that meant Medicaid or MCO funding can either close your entity, which we saw happen, and we advocated against that happening. We actually had one agency that was billing their MCOs, had not been paid for about 6 months, had gone on loans, and ultimately ended up closing. But we did a lot of advocacy to try to prevent that, because there are very few agencies that provide and focus services for tribal members. So, Medicaid billing and billing MCOs is critical to the survival of behavioral health services for tribal members. And even now, we have a couple of tribal agencies that are telling us, excuse me, I just had 2 meetings, and I came from a conference where I was also speaking. That sometimes billing is behind 6 months. Now, we know how much billing for behavioral health services is, and the impact that not being paid for a month could have. Now, imagine being behind 6 months of billing for behavioral health services. It has a huge impact on our communities. It also has a huge impact on our staff a lot of the times, because if the agency is not getting paid, that could have an impact on the staff not getting paid. So these are some major concerns. Another huge focus for us as an association at that higher level is ensuring that there is supervision. So that's another thing that we are taking upon ourselves, is to make sure that there is supervision for behavioral health providers. And the only way to grow our behavioral health field in terms of licensed providers is to have supervisors available that can license folks. And so that's a big initiative under the Behavioral Health Providers Association. That goes hand in hand with item 4, which is the workforce development portion of it. We want to make sure that we are growing our behavioral health workforce through not only licensed providers, supervisors, but also CPSWs or um, certified prevention, our peers, because we want to make sure that not only do we have our OPRI system that certifies CPSWs, but also how do we grow the tribal CPSW workforce, right? That has been such an initiative that our providers are saying because we already don't have enough licensed providers, but hand in hand and sometimes even more impactful is the work of our certified peer support workers, right? Because they come with the lived experience. And so, again, growing that workforce to meet the demand, the behavioral health demand within our state. So that's another big component. So we're working a lot with our CPSWs to see if we can branch out and have our own tribal CPSW training and certification program with a lot of peer input, of course. And we actually, at the conference that I was just in this past week, one of the big things that we heard was it's been accomplished in other states. And so there's a backbone, that can serve as our template as we move forward with that initiative. One of the other big things, and this is a reduction of administrative burden, is a huge task that we take on along with the non-tribal providers association. If you are a behavioral health provider, you are very familiar with the administrative burden of not only ensuring that you are entered into the system in order to be able to bill, but then to keep on with providing behavioral health services and all of the paperwork that you have to do in order to be a provider. And so sometimes that hinders the provision of actual services, and that's therapeutic services, which is what the providers will do. And so that's another big task that we are working on. I've already mentioned a little bit about the reimbursement for traditional services, but like I said, we were very involved at the federal level when it came to the Medicaid codes for traditional services and what that would encompass. And there's a lot of give and take when it comes to these services. They're not 100% ideal right now, but they are as close to what we can get them with input from a variety of tribal leaders, mostly tribal leaders, and then our association at the federal level. And so I don't know if the other thing is, like I mentioned, there are Medicaid codes that are available at the federal level that are not open in our state. And so our role is then to bring those up to our state to do the fiscal analysis to ensure, whether or not these Medicaid codes are going to be feasible in our state? Do we have enough funds, and would they be beneficial to our community members to have those Medicaid codes opened? And if they are, then to advocate for those codes to be opened locally in our state so that our providers can bill under them and provide those services. The other big one, and Val and I and Geraldine saw each other often at the Capitol. A big part of it is advocacy, right? Advocacy for the work that we're doing, advocacy for what the work that our providers are doing in behavioral health in our state. So a big piece of everyday work and annual work that has to happen to have this work continue. A big reason of why we started a lot of the work with the association was really because we needed to ensure that there was a bridge and communication with our state agencies. A lot of the times our state agencies pay for big initiatives to happen, and then our providers were completely non-aware of them. So we bring capacity building, we bring a lot of trainings to our association. We have these entities that are hired and paid for by our state to come and give in-depth training to our providers so that they're aware of what's available. For example, eSpert is one of them that used to be under the BHSD at the time, And then when they transitioned to HCA, they handed that over to DOH. But how do providers know what this looks like, and what do the apps look like? What do they provide? And the fact that it's a free service through the state, it's paid by them. Making sure that our providers are aware of all of these. And as Medicaid codes change, as um, evidence-based initiatives end up having a higher copay for them, any type of uh, code change that happens at the state level or initiative that is funded through the state, we want to make sure that our providers are aware of that early on. A big example is SB3, right? Making sure that our providers know that SB3 is out there, that it's happening, that they should get involved, and that they should be talking to the tribal governments as well so that they're involved and that they're aware that this is happening, so that there is a strong voice, especially when we're talking about restructuring our behavioral health services in our state. Our biggest our strongest voice has been to go directly to those that were going to be running it, such as the AOC or the administrative officers of the court and the HCA and the executive committee to say, please ensure that there's tribal voice in here, and that there's tribal behavioral health provider voice in here, and that there's tribal government voice in as you are trying to restructure our behavioral health system. So again, a big thing. Evidence-based practices when it comes to treatment, counseling services, there are some that are held at a higher standard at our state level, such as EMDR, dialectical behavioral health therapy, all of these behavioral health terms, right, and therapies that our providers currently implement. So we want to make sure that there is conversation between the states and behavioral health providers so that we're advising them of what is most effective, what is the best practice, and then vice versa, informing our providers about what the state is considering some of the top tiered treatment practices. Grant writing and funding. Not only have I provided TA to this group and training to this group on grant writing initiatives and evaluation, but also to our association and bringing our state funders to our association so that they know what are some of the barriers. I'm asked often, why do tribes not apply to funding that the state provides? And a lot of the times it's a short turnaround time. They don't find out about it till the last minute. They have to jump through their own internal legal hoops. And so we've been able to increase the time allotted to providers to apply for grants at the state level. We've also been able to separate funds so that they're specific to tribal behavioral health agencies or to tribal agencies. So that they don't have to compete with non-tribal, because sometimes that is a huge barrier as well. So we've been able to kind of advocate around those around that topic. Ultimately, really our goal is to have a strong unified tribal voice when it comes to behavioral health initiatives. Okay. Some of the other priorities and things that we work on is we do provide a lot of technical assistance and capacity building and trainings. And today we heard a little bit at our meeting about mental health first aid and QPR, which are addressing suicide. And I specifically brought those up because it is Suicide Awareness and DV month and mental health awareness month. And so a lot of our behavioral health providers are not only providing behavioral health services, but they're also providing training to their community around behavioral health topics. They're also bringing in awareness. Like we, as an association, have had contracts with 988, and we still bring in Steph and her team on Tribal 988, provide awareness and build awareness around that. We've also provided a lot of capacity building to our 988 call center to make sure that there's culturally appropriate answering of phone calls, especially if a tribal community member calls in with things that could be confused and not understood as a cultural concept versus a mental health concept. We've also collaborated with Keep NM Alive, which is focusing on opioid overdose and kind of bringing awareness around that. A big component is behavioral health integration and SBIRT, screening, brief intervention, referral to treatment, is something that I've been working on and training on since I can remember, I think since 2010. And I am known for training emergency departments and medical clinics on the New Mexico SBIRT model, which is an intense, in-depth model where I'm training the EDs and the clinics to provide SBIRT services to anyone that crosses their doors. There's other SBIRT, like I mentioned, eSBIRT, like the 3-question SBIRT. There's a variety of SBIRTs that are out there. And any type of screening, brief intervention, or referral to treatment training, I feel is a positive out in our communities. We need people to know about it, and we also need folks to early identify if there could be a potential problem with substance use, and that's really the goal of SBIRT, is to address and provide services early on before it becomes a treatment situation. If possible, right? We obviously referral to treatment is part of the name, so we do refer to treatment as well. And emergency response coordination and collaboration, we have worked a lot with being kind of one of the first responders and the organizers of first response teams, including peer support workers that are sent out for emergency things like fires, the Gallup emergency that happened during ceremonial. That was a huge, elaborate coordination of departments. There was a recent one that we were called in for as well. And then the tribal community decided to address it on their own. But again, being involved and being available to help during these emergency response situations where we can send a group of behavioral health providers, we can send a group of folks that are known for addressing behavioral health in cultural ways. So that's a service that we do provide as well. And then, of course, prevention within the behavioral health departments that I mentioned. A lot of our tribal behavioral health have prevention embedded within them. So that includes the Narcan distribution and training, direct services, harm reduction, storing and disposal, education and training, and then educational material distribution. It also includes not only for opioid use, but also for alcohol. So there's a lot of collaboration that takes place. In terms of how we became, so I do want to address the history of it. So we had a 2020, I had a 2020 grant looking at Medicaid needs in our state. So this was a statewide assessment grant in partnership with UNM. And so we were actually just looking at what Medicaid codes are being utilized across the state. And one of the main things that came out of this was not related to Medicaid. It was actually the need for this provider association group. And so it began with a 4-person volunteer group, and we are still a 4-person volunteer group. We actually formed during the pandemic on March 19th of 2021. And we received endorsements, but we hadn't received any funding for our association. I applied for an Indian Affairs grant to kind of hold our first conference, and we were lucky enough to hold our first conference on June 30th of this year. And so we were super happy about that. That was our very first grant. And then our second grant, it came through a coordinated effort with providers. And actually, I think I have a slide on that coming up. But so our mission is really to advocate as a unified tribal voice for quality behavioral health systems that are accessible and responsive to tribal matters across our state. And that's kind of everything that I've talked about in terms of behavioral health. That is our focus. That is what we are moving strong on, and we are growing, and we've gotten recognition from the state senate, from our legislative sessions and from the different departments for the work that we do. We've also gotten recognition from other states on the work that we've done. This is our core team, and I do want to acknowledge them because they've all been with me as volunteers since we started. No payment, right? This is a lot of hard work. So I want to recognize Teresa Gomez, Melanie Montoya, Lana Valdez, and Jen Nunez for sticking through this entire process with me. Uh-oh, there's my computer acting up again. Okay. Oh, so real quickly, these are some of the partners that we have, all of the tribal communities that we're working with, and some of our non-tribal partners and the MCOs that we work with. They all come in and provide information about the services that they offer, how we can collaborate, and again, other partners outside of the state as well. Um, so some of the services, I've mentioned some, so I won't go too much into detail, but again, that strong communication, right, in collaboration with all of our state departments. SB3, again, from the very beginning, ensuring that there was tribal engagement. Uh, I can't just really mention the importance of this, especially as the 13 regions break into their own 13 regions, and the tribes are embedded within each of those 13 regions. There's been some major concern, and we know that this is kind of how it has to be. There's been a lot of questions about can it be any different, but again, tribes are not a unified voice anymore because now they're broken down into these 13 regions. And so we need to make sure that there is a strong voice within those 13 regions. And so I know now that we have Val, Steph, and myself involved in this process that we are going to ensure that that does happen. There's some strong advocacy behind it right now. Funding, obviously, is one of the things that we ensure that our tribal communities as behavioral health providers have funding for implementing their behavioral health services. Some behavioral health services, and some people don't know this, but some behavioral health services are not covered under Medicaid or MCOs. So, there needs to be some funding associated with that. Also, some of our ongoing goals are capacity building. We're going to continue doing some capacity building within our behavioral health providers and on a variety of topics. We want to continue our annual conference because it also brings in capacity building. But it was such a successful conference this year. We had over 100 people, and it was our very first one. So we were super excited to be able to have that. Again, the tribal peer support certification, increasing the number of peer support workers, but also establishing a tribal track. And then community building and collaboration, right? I am a strong believer that we are stronger together. And so true collaboration needs to happen, and especially in times like the ones that we're facing, the funding decreases that are happening, and it is a very tumultuous time right now, and so we are stronger together, and we are advocating for some funds to ensure that we have some growth. I always tell Val, I know she says our strong, powerful, mighty group. And to me, I'm like, you have 3 paid staff. That's amazing. Like, I want some paid staff so that we can get to that level of being super strong. And if we have gotten this far on a volunteer basis, I could just imagine how far we can get if we had some dedicated time. So that tells you a little bit about where we're going. Some harm reduction, tribal harm reduction, it is part of behavioral health. We just collaborated on with a couple of partners to make sure that we gave out 16 grants to tribal providers. All of the grants were $100,000. We also sent them to different trainings, out of state trainings for capacity building. So that is a huge accomplishment. I don't think this has ever happened where we have been able to fund 16 communities to address tribal harm reduction in tribally cultural ways. So there's cultural grounding and methods that are being addressed. So yes, some of them are doing Narcan distribution, but a lot of them are addressing harm reduction in a completely cultural way that does not even include Narcan distribution. So this is a 1-year funding, unfortunately, but we are advocating to continue this funding moving forward because it's a huge success for us. And our partners with this are Vital Strategies and Americans for Indian Opportunity, and of course, our association. So this was exciting for us to be able to do this year. A little bit of everything. I've talked about most of these, but SB3 and the alcohol liquor excise tax has been another huge initiative that I've been working on for a very long time, especially with our association, getting extremely involved and making sure that there is a huge allotment that goes directly to tribal communities so that they can address behavioral health needs as they see fit in their community. Last year, the bill included about $60 million that would go to directly to tribes. The bill did not pass. This year, I think because the percentages have been dropped a little bit, it is an increase in tax, but it's a smaller increase in tax, and therefore the amount allocated that would be allocated to tribes would also drop because the percentages dropped, but it's still a significant amount. We're talking about, close to $40 million. So it's something that I'll probably ask Val to help out again. I know that they were advocates alongside us last year in support of that initiative. And so ask for your support as well so that tribes can get funding to address that. This funding can be used to have a youth treatment center, which is very needed in our state, right? And a couple of other things, but I want to make sure that this is just some media on some of this is obviously at the Capitol, some advocacy that we've been doing. We were very instrumental in raising awareness of the Medicaid fraud that happened in Arizona, and all of our tribal members that were being picked up and taken to Arizona and left there. And so we advocated to address this early on. And again, just, trying to bring awareness to what is happening in our state when it comes to behavioral health. This is just some national support and endorsements that we have received. And then in terms of ongoing efforts, we still have to work a lot on recruitment and expansion because in tribal behavioral health departments, what we've seen is that there's a turnaround in terms of staffing, right? And sometimes there's a gap before someone is rehired. Sometimes that gap could be 6 months. And so recruitment and expansion has to be an ongoing effort for us, securing funding. Some of these I've talked about. Timely crisis support is a big one for us because I'll get a call like on a Friday and they need us to be there like on that Saturday to kind of address the crisis. So that takes a lot of coordination and timely response. And again, wanting to make sure that we have, a lasting impact. And that means recurring funding for our association and all the efforts that are taking place. This is how you can contact us. And I just want to thank you all for having me and for oh, sorry, this is when we had an introduction of Nick, who we collaborate with a lot. But thank you all so much for your time, for letting me present and tell you a little bit about our association. Thank you.
Thank you. Is there any questions for Cindy? Let's see if we've got anything in the chat.
Well, while people reflect and include any questions or comments or feedback for Cindy, I just want to chime in and give Cindy so much gratitude for the work, the hard work, as we say at the Alliance, that you've been leading, Cindy, for years through COVID and bringing the Tribal Behavioral Health Providers Professional Association to fruition. That is a labor of love in service of tribal communities. And as we all, both counties and tribal communities, come together to actualize, right, this SB3 behavioral health Reform and Investment Act. I think there's obviously a shared commitment here to make sure that all of the diverse voices that represent all of our communities across the state are at the table, especially with these listening sessions that are going to be coming up, and with informing the prioritization and planning process. And this is where all of us come in: Cindy's network, the Alliance, County and Tribal Health Councils, and we are all part of various types of networks in our respective fields, services, areas of expertise, community engagement. So we're so clearly deeply aligned, and this is where we get to lean into each other, link arms together, and make sure that all of our community voices are heard clearly and loudly. So thank you, Cindy, sorry, for your leadership and your dedication to New Mexico.
Thank
Yeah.
you. Thank you all.
Yeah. Any questions, reflections, or digital feedback here? And if not, and Cindy, you'll be able to share. I know this is being recorded, but you'll be able to share some highlights so folks can follow up with you individually should they have additional questions or want to have deeper conversations with you and your team.
Yeah, absolutely. And I'll put my email on in the chat as well if anyone has any questions. Thank you.
Beautiful, beautiful. Well, with that, Joseph, do you want to go over some of the timely links, updates that you've included in the chat for our friends here today?
Sure, apologies. Yes, they're the same things that I announced earlier. I will share the screen and I will show them again just for review. Okay, so we have got another reminder of, sorry, my computer is not cooperating. It's drawing for some reason. Okay, almost there. Well, I'll just go with this. We've got our advocacy training with Carter Bundy on November 5th, and that's from 12 to 2 p.m. We've got our federal and fundraising training that happens on November 14th. Those links are both in the chat. We also want to remind you of the Community Collaborative Forum that's taking place in November. Please join us for that. And last but not least, I always also want to remind you for the annual letters that we make to present to our legislators to make sure that we get funding for the good work that we're doing with our health councils across the state. So all of the links are in the chat for that. If you have any questions or comments or concerns about that, please reach out to us. Thank you.
And I would just chime in, folks, we've also included the link to the Community Collaborative Forum that's coming up November 6th. Speaking of behavioral health, we are going to have timely updates on SB3 progress, you know, the SIM workshops, the community listening sessions. By that time, we will have some informative updates. We're also going to have our friends from the Healthcare Authority provide a thorough overview of the closed loop referral system, its objectives, services, and ways and opportunities that we can all collaborate. And third, we're going to have our friends from the New Mexico Department of Transportation present on key findings from their rural transportation study that they conducted earlier this spring. As we know, transportation is a significant barrier throughout New Mexico for accessing a myriad of services that our communities need. So perfect timing, you know, for the Community Collaborative Forum. So we invite you all to register. Thank you so much. Over to you, Joseph, if there are any other comments or folks have any questions given, this is an open forum. So if folks have any other questions, let us know. We're here.
Well, thank you again, Cindy, not only for presenting today, but the amazing work that you're doing across the state and have been doing across the state. Especially as far as today, after doing a conference and having a busy day, that's a lot going on a Friday, especially. So thank you so much for taking the time with us today. And thank you everyone for showing up today and learning more about what's going on in our amazing state and how that we can support each other in making our state a better place. Have a happy Friday, everyone. And if there's nothing else anyone has to add, we will go ahead and gift you 10 minutes for your day. Amazing. Have a happy weekend, everyone. Goodbye.